we move on to this very familiar situations of hard nuclei and cataracts, and there is no better person than MAHIPAL here to talk on it. Thank you. MAHIPAL.
Hello. Yeah. Thank you very much, Abe, and thank you, Dr. Titial, for having me in this course. Always a pleasure being here. I'll be talking about phacoemulsification in hard cataracts. And hard cataracts, soft cataracts, subluxated polars, etc., they remain challenges even for the most experienced surgeon. So when you are looking at a hard cataract, essentially what I'll wish to say is that one needs to diagnose a hard cataract pre-operatively. It shouldn't be that you go on the table and you feel that there is something that I need to do and it's a hard cataract. Now there are several studies that have been done. This is the famous Swedish capsule rupture study in which it has been shown that white and brunescent and hard cataracts are associated with increased risk of capsular complications. It happens to the best of us. Obviously, the machines and the techniques have improved significantly, and this is what I am going to tell as to what should be the techniques, etc., which can reduce the incidence of complications, specifically posterior capsular rupture and corneal problems. Now, the first and the foremost important thing is that pre-operatively, as I said in the OPD, before you are taking the patient for surgery, there are certain pre-operative considerations that you need to have. And these considerations would be pupillary dilatation. When you are looking at pupillary dilatation, what is very, very important is that you should also take the history of a patient being on tamsulosin, because nowadays hard cataract has been sitting for long, so these are aged patients and they are, the urologists are using tamsulosin very, very often. Then it is very important to look at the state of corneal endothelium. It's a standard of care for us that we do a specular microscopy. If you don't have, you do a good specular reflection on the slit lamp to see the corneal endothelium. You need to look at the zonular integrity, because obviously you know that there is going to be some more manipulation. The morphology of the cataract needs to be studied, and if possible, the posterior segment evaluation should be done. Now, what are the challenges that you have in a hard cataract? There are a couple of challenges. First is the compromised visibility, and that is because when you are doing the procedure, there could be an absence of red reflex. This could be also compromised visibility because of the milky fluid. When you are doing the capsulorhexis, there could be a problem because often these hard cataracts have some fibrosis which should be associated, and you may have difficulty in doing a capsulotomy. Then when you look at these hard cataracts, they tend to be sitting there for long and they could be swollen, so you have less space for surgical manipulation. Hydrodissection, hydrodelination could be difficult, but I think this is the bugbear where you have leathery fibers which may be difficult to separate completely, and that is the problem which I'll be discussing. Now, when you are looking at the nucleus essentially, the anatomy is that it is the center which is the thickest in the nucleus, and the leathery fibers go and interdigitate right at the bottom. So it is very, very important for you to break the backbone or the spine of the nucleus, which is of importance. Now, how you break or how you do the nucleotomy could be that you could do a trench, you could do a direct splitting, or you could do a chopping. Now, when you are done a trench, the important thing is that this is how the forces have to work, and the trench needs to be pretty deep. You need to be about 90% thickness of the nucleus in the center. The periphery will break more easily, but it is the center that needs to be broken. Now, if you have a trench which is not deep, you can see that the vector forces are working like this. But if the trench is deep and you have the two instruments, then the forces work in this direction, and therefore that is how the backbone will be cracked. So the important key message that I want to give you is that the depth of the trench is very, very important, and the placements of the two instruments by which you are going to crack it or split it, that needs to be down below so that you are able to do this. Nuclear emulsification, chopping techniques, you can do divide, conquer, primary, stop and chop, crater. I won't, that's a choice of the surgeon. My personal choice is a primary chop. And modifications of the primary chop for rock hard cataracts could be that you could make a crater in the center, or sculpt and then chop, or you can drill a hole and then chop. So these modifications allow safer in the bag chopping and emulsification. So that is something very, very important. So this is, I'll show you a video which is maybe a decade old and a video that we have done now. So this you can see is again on a good signature. This was the first signature machine. Now you have Signature Pro and Veritas. But you can see that I made a trench and then I have gone deep in. And now you see that I am separating the fibers. So what is very, very important is, look here, crack in the midline. Can you see this crack in the midline? Until, of course, you are able to crack in the midline, these things will interdigitate and come out together. Now again, I have rotated it 180 degree, and you can see again that I am trying to get this split. Can you see this? Just watch. Once you have got this split right into the center, then only try to remove the fragments. Understood? Now you can see there is no epinucleus cushion. So you need to put viscoelastic, viscoat that we have put. And again, you can see I'm chopping from the center. Hold it deep, bury deep, go to 90% of the depth, 80-90%, and again wait till you have the chopper separate the nucleus right till the backbone of the nucleus. So that is something very, very, look at the color of the nucleus. You can see it's a dark brown black cataract. And again, you can use the chopper to hold it and feed it into the nucleus into the probe. Now, mind you, you can see the vacuum going up to 500. This is a 19 gauge needle. I normally don't use thinner needles because they tend to get clogged with the nuclear material which is there. And you can see the rock stability even at such high aspiration and such high vacuum. So again, you can see, look at the depth. You need to be careful that we are away from the endothelium. As also what we have to see is that there is no epinuclear cushion. So you have to maintain a balance, and you can see that this is now the pretty much the end of the nucleus, and that's the IA, and you go ahead. Now this was a case, I would say one of the hardest cases that I have done vis-a-vis on femto. So my associate said that we should go ahead and do an SICS. I don't know how to do an SICS, but I said, let me just try the phacoemulsification. So you can see this is a pre-cut nucleus. We pass the femto incisions 3 times. We make a larger capsular excess. So one important thing in hard cataracts is that do not make a small capsular excess, because you will not be able to take out the nuclear fragments in a small capsular excess. So this is a much harder nucleus. So we have made a bigger, which is a 5.2 on femto, which actually would become about 5.5. Now again, you can see I have sculpted, though there is a pre-cut. I'll just show you that there is a pre-cut which happens even in black cataract. It's the white cataract. Just can you see these bubbles that came out? So what did these bubbles show? These bubbles showed that the femto laser has been able to penetrate, and again you can see that this is a black cataract, blacker than what I showed you earlier, and we were able to split it in the center. So you can see that the center one has been able to split, and you can see again that in this particular case you can again see that it is more black than the one that I showed you. I have brought out the fragment into the pupillary plane, and you can see that again, because it has been femto chopped before, we are able to get the break of the nuclear fragment much, much easier. And again, we are using a very high vacuum 19 gauge needle that we are using, and we are able to get the separation of the pieces. So you can see again, can you see the color of the nucleus? So we have again been able to separate. Essentially, rock solid chamber, good machine, know the settings of the machine. It is not that you are using a lower end machine and you take it to 500 vacuum and you get a flow rate of 45, 50. You're going to have a surge and you are going to have problems. It is depending on the machines. You have to have the proper chopping. You have to break the backbone of the nucleus, which is very, very important. Stressing again and again, whether you do a crater, whether you do a sculpt, whether you do a trench, it does not matter. But till you are able to break the nucleus right in the center, you will not be able to do justice. And you can see that finally the entire nucleus is being devoured by the phaco, and you can see this is a good capsular excess that we are having. So intraoperatively, difficult situations during nuclear repulsification have to be looked at, but incomplete separation of nuclear fragments following chopping with the leathery fibers being tenacious is what makes it much more difficult. That is something very, very important. An absence of epinuclear cushion for the protection of posterior capsule is important, and you need to use the parameters which you are comfortable with. In case you have a PCT, please do not continue fishing about. You need to detect it early and optimal management. If you have to close the incision and leave it, thank you. Then under those circumstances, it is very good. You can have your posterior segment person go ahead. Dispersive OVD, which is chondroitin sulfate, can tamponade a posterior capsular tear, and anterior vitrectomy could be used for vitreous prolapse cases. Now, post-operatively, you are working with a prolonged surgical time, so there would be an increased risk of AC inflammation and cystoid macular edema. So intensive topical steroids are needed. Cycloplegics are something that I give in such hard cases. Even if I do them under block, I normally do not do under topical, because if you have to convert, and I give a subconj atropine in these cases so that the inflammation can be reduced. And to prevent CME, you need to have the NSAID continued for about 3 weeks. So I think that is the important thing. IOP needs to be monitored because you have used a lot of chondroitin sulfate to protect the endothelium. So friends, hard cataract is a difficult nut to crack, but if you follow the proper techniques and you take the help of good machines, good technology, which could be good machines, or if you could have a femtolaser, I think dealing with a hard cataract is something that can be done easily with a phacoemulsification. Thank you very much for your kind attention.
Thank you, Dr. Mahipal, sir. And we know that hard cataracts can be very difficult to manage sometimes, but looking into a basic aspect of managing cataract, if you look into a hardness, do a proper technique, safeguard the endothelium, most often the results are very gratifying in these cases also. And femtosecond laser would definitely be advantageous in these cases also. If you can at least make a nucleus softer, then subsequent energy use will be less and damage to the endothelium, and the surrounding uveal tissue will be also less. So effectively look into not only intraoperative advantage, it has an advantage in the post-op period also, where inflammation will be less in these cases. Thank you, sir, for highlighting all these important tips.